So let's begin talking about coronary pathology. So Unit 2, we introduced kind of the basic review of a few little vascular things because it's going to be important when we start talking about heart pathology. And then we walked through the big cardiovascular risk factors, and hopefully, if not already, you can see how they will feed into the actual development of the pathology of these diseases. For the heart, what I'm going to do, as I promised at the very beginning of the class, is that I do weave in some physiology review as we go. So for coronary pathology, I'm actually going to start with a disease. We're going to start with congestive heart failure, and we're going to use that as a tool to go through your cardiac physiology review. So we'll be talking about a disease so that it feels fresh and new and you don't feel like you're sitting in a basic physiology course. But this will be the time when I'm just going to kind of weave in some of those basic concepts of cardiac physiology to make sure that we're all kind of on the same level playing field when trying to understand how the heart works. So the disease that we're going to use for our review is congestive heart failure, CHF. Now, heart failure gets complicated pretty quickly. There's a lot of stuff going on because there's a right and a left heart, and we're going to go through a bunch of different ways in which the heart can start to fail. But I want to simplify it for you right in the beginning. Every version, every kind, every cause of heart failure actually has the same clinical consequence. When someone has congestive heart failure, they have reduced cardiac output. All types of heart failure is reduced cardiac output. Cardiac output is how much blood is being pumped out of the heart per minute, right? So we're in liters per minute. And when you have heart failure, you will have a reduced cardiac output. So I often joke about the degree to which I hope you remember certain things in this class, and there are definitely some nitty-gritty details that I know will fall by the wayside and will not stay permanently in your mind. But then there are those facts, those things that I want to have so deeply rooted in your mind that if I were to sneak into your apartment and wake you from a dead sleep and say, what does all kinds of heart failure have in common? Even if you were deep, deep, deep in sleep, you could wake up and be like, it's reduced cardiac output, of course. So this is the one, if you remember this, kind of everything else makes sense. So if you start getting tangled up, just keep going back. All right, if they have heart failure, they have reduced cardiac output, and everything will come back to that and it will start to make sense. There's a lot of nitty-gritty details, but no matter what happens, all of heart failure is reduced cardiac output. Why someone might end up with heart failure can either be a problem within the heart, intrinsic pathology, or it could actually be something outside of the heart. Let's first talk about some intrinsic pathology. So you have a number of things listed in your notes here. On the screen right now, you can see a dilated cardiomyopathy. Holy smokes, look at this heart. This is compared to normal on the right. This is a huge heart with very, very thin walls. This heart is not going to be able to pump very well. I mean, look at how thick a normal ventricular wall is. Thin little puny walls, big, huge volume. This heart's going to be in some trouble. The other side of that, listed in your notes, is hypertrophic cardiomyopathy. Hypertrophic, you guys know hypertrophy, increased size of the cells. Hypertrophic cardiomyopathy, the walls get so fat that there's no space for the blood. This is the ventricle. It's teeny, I can't spell ventricle. It's teeny tiny. How can you get any blood in this heart to pump it all? So a patient might end up in heart failure because something is wrong with their heart that is leading to reduced cardiac output. Because again, all heart failure really is reduced cardiac output. The heart actually might be fine. You could have a perfectly healthy heart and end up in heart failure because of external factors. The most common is uncontrolled hypertension. The heart has to pump the blood out into the periphery. In order for the aortic valve to open, to let the blood leave the ventricle, the heart has to squeeze and generate a pressure greater than the pressure in the aorta. That's the only way to open the valve and push the blood out of the heart. So if you have really high pressure in the aorta, think of how much more pressure the heart has to generate just to push any blood forward. So because there's so much back pressure on the heart, this can result in reduced cardiac output. Even if the heart is perfectly fine, and if you could just lower their blood pressure, the cardiac output would be normal. Volume overload is another example. There's just too much liquid being returned to the heart. It can't keep up and it becomes overloaded, and you can get reduced cardiac output. That's supposed to be an arrow, but it got messy. There's a number of hormonal disorders, and you don't have to write these down. We'll go through some of these. Like hyperthyroidism can often result in too much demand on the heart. Patients can end up in heart failure during pregnancy because of the huge new demand on the heart. But in all of these cases, these external factors, there's something that's putting an increased demand on the heart that's causing the dysfunction. Okay, so something's putting increased demand on the heart that's causing the dysfunction. So while all heart failure is reduced cardiac output, the cause can either be something wrong with the heart, or it could be something in the body that's putting too much demand on the heart. Our next subcategory of heart failure is whether it's acute or chronic. Acute is exactly what it sounds like. It comes on suddenly. So if we look at the examples, this might help make sense. So an example of acute heart failure could be after a myocardial infarction. So 10 minutes ago, their blood was receiving heart. They had an ulceration and rupture of an atherosclerosis. They formed a clot, and they suddenly have no blood flow going to their ventricle. Well, that is going to very suddenly reduce the ability of the ventricle to contract and push blood out. This would very suddenly cause a drop in cardiac output. 10 minutes ago, normal cardiac output. Now, bam, reduced cardiac output. This is acute life-threatening. Oh, excuse me, I'm reading the slide now as I'm going. Acute heart failure, how about that? I'm already getting to my next thought. This is an example of acute heart failure. And the reason it's life-threatening is because there is no time to adapt. So when you hear the word heart failure, all that means is that there's a reduced cardiac output. But somebody who is in acute heart failure, this is a much more serious clinical condition that can very likely lead to death, because there is no time for the body to adapt. It is just suddenly deprived of a normal cardiac output. And that's in comparison to chronic. Chronic heart failure is what you're more familiar hearing about. If you've ever heard a patient, a family member, a person in a TV show walk in and say, oh yeah, I've got heart failure. Chronic heart failure can go on for months or even years. So this is a very long-term condition. The number one cause of chronic heart failure is coronary artery disease. And coronary artery disease is just a fancy way of saying they have atherosclerosis in their coronary arteries. We will go through this in a minute. If you have coronary artery disease and your coronary vessels are filled with atherosclerosis, you're not going to be able to deliver enough blood flow and oxygen to the heart. So over time, the heart gets sicker and sicker because of the failure to deliver enough nutrients. So the reason that chronic heart failure can go on for months or years is that it's typically slower in its progression, and the body has a chance to kind of adapt and try to make do with the condition that it has. So we've talked about separating heart failure into its cause, either intrinsic or extrinsic. Then we said, let's talk about heart failure in terms of its timing, either acute or chronic. Now we can further talk about heart failure in terms of what part of the cardiac cycle is affected or kind of causing the reduced cardiac output. And this is going to cause us to review the concepts of systole and diastole. The figure on the slide is Wigger's diagram, and this is a extremely classic physiological diagram that illustrates the cardiac cycle. If you are at all questioning your cardiac physiology, I strongly recommend going through this figure and seeing if you can explain the relationship between pressure in both the heart, these are the heart pressures here, and the primary vessel or the aorta. Here, I'll just draw a little vessel there. Can you compare and describe the pressures in these two areas? Why they're the same during some times and they're very different during others. Spoiler alert, they're very different during diastole and they are basically the same during systole. And relate that to the volume in the heart. So as I'm sure you guys remember, diastole is when the heart is at rest. And when the heart is at rest, you need extremely low pressures so that blood can enter the heart. So diastole is when we fill the heart. I often say you can kind of think of diastole as, the heart's just like a saggy bag that's just sitting there. It's not doing anything. I think the heart's so sexy and exciting, it contracts, it's got electricity. But during diastole, it's just a saggy bag. It's just a saggy bag sitting there, letting blood enter it. There's almost zero pressure because the pressure in the heart has to be lower than the pressure in the veins. Blood will always move from an area of high pressure to low pressure. So if the pressure in the heart is higher than the pressure in the veins, the heart does not fill. So during diastole, the pressure in our heart is almost zero, which is what allows the volume to increase over time. So during diastole, the heart has to be very relaxed. It has to be really compliant, which is another word for stretchy, so that when you take that saggy bag and start filling it with blood, it can just stretch and accommodate that blood. So diastole is the time when the heart receives blood from the venous system. Systole is the exciting, sexy time of the heart. That is when the heart actually contracts, right? So this is the contraction of the heart. Contraction of heart. This is when we squeeze the blood out and push it out into the periphery. We often describe the strength of systole as the ejection fraction. And this is a really helpful, often abbreviated EF. The ejection fraction is a really helpful way of describing how successful systole is, because ejection fraction is the stroke volume, or the amount of blood that leaves the heart in one beat, divided by the end diastolic volume. And then you just multiply that by 100 to make it a percent. So what this equation is showing us is, or what it is saying is, of all the volume that got in the heart at the end of diastole. So at the end of diastole, we filled the heart. This is our end diastolic volume. How much did we get in there in the first place? Of all the volume that gets in, how much do we pump out? What's our stroke volume? And normally, the heart is not a completely efficient pump. It does not pump 100% of the blood out. I think that's an important thing to know if that's not already intuitively in your head. I think sometimes we give the heart way too much credit. We think of it like emptying during systole and then refilling during diastole. But truly, the heart is a muscle that squeezes and it tries to get the blood out, but normal ejection fraction is 55 to 70%. That means that 30 to 40% of the blood that was in the heart at the end of diastole is still there for the next beat. We do not like wring the heart out and squeeze every little drop out. If somebody has a heart failure of reduced ejection fraction, this number would go down, right? So a heart failure patient might have less than 30 to 40% ejection fraction if that's the factor of their heart that's causing the heart failure. So that's just a little review of those 2 cardiac cycles. If that sounded super simple reviewy to you, you're probably pretty good. If you were kind of needing that review, I encourage you to either go back through your phys notes and just sort of review the cardiac cycle. Use the Wigger's diagram if that would work for you. Take out just one of your classic phys textbooks and read this area. I think it really might help when you're trying to interpret the more complex pathology to understand normal cardiac physiology. Oh, I got to clear off all my chicken scratch here. I like this animation because one of the things I think we often forget is that during diastole, the blood is pouring through the atria and filling the ventricle the whole time. I think sometimes we have this image in our mind that first the atria get filled, then they contract, then the ventricle gets filled. But truly the blood just pours right through, and that right before systole starts, you do get an atrial contraction, and you see the atria beats just a second before, but that is what's referred to as a primer pump. And if you look at the volume curve here, you can see that during the entire period of diastole, so from between my red lines is all diastole here. This is when the heart is filling. Ventricular volume is going up the whole time. And then right at the end, right where this little star is, we get an atrial contraction. For those of you who are familiar with EKG, you can see this associated with the P wave. We're not going to talk about EKG much in this class. We will go through our full EKG and cardiopulm. But this little contraction of the atria gives you a little kick on volume and an extra little hit. And it stretches the ventricle. It gives a little improvement in our length tension curve to allow for a really great ventricular contraction. So all of heart failure is a reduced cardiac output, but the cause may be during systole or the cause could be during diastole. So if you have heart failure that is a result of problems during systole, this is sometimes referred to as HFrEF, which stands for heart failure with reduced ejection fraction. HFrEF, HFrEF, heart failure of reduced ejection fraction. That helps to clinically separate these patients out as to what's causing the reduced cardiac output. So if the problem is during systole, and systole is when the heart's contracting, this is a failure to maintain cardiac output because of a reduced ability to pump. So systolic heart failure is a reduced ability to pump, which is going to reduce your ejection fraction. So on the previous slide, I mentioned that it could be less than 30 to 40% would be considered a reduced ejection fraction. Someone who has severe heart failure of reduced ejection fraction could have less than 10% of their end diastolic volume being pumped out each beat. So how does this happen? Why can't the heart pump anymore? What is the problem? Well, the first one is there might be an impaired contractility. Contractility is the strength of the contraction. If that's an elusive concept for you at all, sometimes it's helpful to think of our peripheral muscles. Low contractility would be taking your arm and lifting a pencil with your bicep, right? You're contracting your muscle. Your muscle is going through the cross-bridge cycle and you're generating force. It's just a teeny tiny bit of force. Your exact same bicep, you could pick up a 20-pound weight and you could lift it to the same range of motion. You would have generated a greater amount of force. That translates to contractility in the heart. The heart can squeeze harder. And the harder it squeezes, the more blood it should push out. So if somebody is in systolic heart failure, they may have a decreased ability to generate that force. So there's an impairment in the muscle. Here we see a picture of a dilated heart with a teeny tiny thin ventricle wall. That's not going to generate enough force to squeeze that blood out. You might see impaired contractility of a ventricle that's gone through a myocardial infarction. If a big hunk of your ventricle isn't getting any blood, it's not going to contract. And if a big hunk of your ventricle isn't contracting, you're going to have reduced contractility. If the ventricle can't contract with enough force to push the blood out, you are going to get a reduced ejection fraction and a reduced cardiac output, which is all of heart failure. The second reason that the heart might be having a difficult time pumping is an elevated afterload. So as a reminder, afterload is the pressure that the heart is pumping into. So we often think of afterload as being kind of synonymous with aortic pressure, because that is the peripheral vessel that the left side of our heart is pumping into. Afterload represents the pressure the heart has to pump into, or put another way, the pressure the heart must overcome to push any blood out. So if we go back to the Wigger's diagram, you can see aortic pressure is here in gray, and ventricular pressure is here in blue. At the start of systole, kind of marked here with the star, at the start of systole, the ventricle begins to contract. But this is called an isovolumic contraction, because the pressure in the ventricle is still less than the pressure in the aorta. If the aortic pressure is greater than the ventricle, the aortic valve is closed. So no blood can leave. So the heart continues to squeeze, it continues to squeeze, and then you reach this critical point where the pressure in the ventricle is greater than the pressure in the aorta. The valve opens and blood can leave. If you increased this pressure, the heart would have to generate so much more ventricular pressure just to get to the place where it can open the aortic valve, let alone actually push blood out on top of it. So an elevated afterload is so much pressure the heart has to pump into, it can't push the blood out. So these are both causes of systolic heart failure because there's a reduction in ejection fraction, but one might be a little bit more on the fault of the heart, or the other is a fault on the periphery that maybe perhaps a normal heart is trying to pump into. So diastolic heart failure is the other option when we're talking about which part of the cardiac cycle is to blame for the reduction in cardiac output. Another name for diastolic heart failure is HFpEF, HFpEF, which stands for heart failure with preserved ejection fraction. HFpEF is heart failure with preserved ejection fraction. So diastole is the time when the heart has to fill. So diastolic heart failure is heart failure that's a result of a reduced ability to fill. So here are some examples. You might have something outside of the heart that is preventing the heart from expanding. Remember, it's just a saggy bag, and it has to accept the blood, kind of like a water balloon blowing up. If you almost picture that in your mind, picture a water balloon. When the water first enters it, right, there's a lot of the balloon's still kind of saggy, and then you kind of slowly take up all the slack on the walls of the water balloon. But you could keep adding, right, more water, and what would happen? The walls would stretch. But what if that water balloon, what if you're holding it really tight in your hand and you don't let it stretch at all? Well, it's going to limit how much water you can put in the balloon. That happens in clinical pathology. A big example of this is pericardial effusion. So our heart is in a sac, and if fluid starts to accumulate around it, there will be pressure building on the outside of the heart, and you will not be able to stretch the walls of the heart to accommodate the blood. So during diastole, you are not going to get enough volume in the first place because it can't stretch beyond that external pressure that's holding it. Increased wall thickness is what we see here in the picture on the slide. You can see the size of that ventricular wall is so big that it narrows the size or the available volume of the ventricle. So increased wall thickness or cardiac hypertrophy can lead to diastolic heart failure because of a decreased ability to fill because there just isn't space. The whole space of the heart's taken up with the size of the wall. The third one on the list is a delayed relaxation. So, you just had this big contraction. All those myocytes were, going full steam ahead during systole and contracting with all their might. And then they very quickly have to, get rid of all that intracellular calcium and relax all their contractile apparatus to become the saggy bag. If anything slows that process down, makes it take longer for the heart to relax after the contraction, well, that would create a stiffer wall because there would still be muscular tone to the ventricle wall. So if you can't fully relax, you won't be able to fully fill. And this is actually a phenomenon that we just see happening normally with age. As we age, we get worse at transitioning between systole and diastole. It takes us longer to relax. So all of heart failure, no matter what side of the heart is coming from, is a reduced cardiac output. You're starting to pick up on the fact that I'm trying to brainwash you. All of heart failure is reduced cardiac output, but the cause could be either during the cardiac cycle of systole, when the heart is contracting could be the problem, or perhaps the contractility and the ability to pump is fine, but the problem could be during diastole. And you might have difficulty filling the heart. I'm going to spend just a few minutes doing a real basic cardiac anatomy review. Every year, when I have students that are kind of working through problems, I have students that have to really think about like left side of the heart goes to which side of the body. And I want that part to get streamlined, and so that we can use kind of the terminology of cardiac anatomy to tell our story instead of having to always think about it. So let's make sure we're on the same page. Don't draw this just yet. Just watch for just a second because I'm going to destroy it. All right, so this is a heart. You guys will find out that for the heart, I like to really not rely on the anatomy, but rather the cartoon heart. Okay, so I like this because it has a right and a left side, right? So we've got our right side over here, our left side over here. But the reason I told you not to draw along yet is because in the physiology of the cardiac system, it actually isn't one thing, right? You actually need to cut this in half because these two sides of the heart don't interact directly. Even though they're all part of one organ, they're actually two separate pumps. So let's redraw this. I'm going to take my heart and I'm going to rip it apart. Oh, she's a heartbreaker. She's a heartbreaker. That's me. Okay, so here is my right side of the heart. And here's, see, it ripped it apart. Oh, it's cracked. It's way over here. Here's our left side of the heart. The reason it's helpful to rip our heart open, well, it's also fun, is to really truly illustrate that these are two separate pumps, right? Because in between the right side of the heart and the left side of the heart are our lungs. So let's start on the right. Let me change the color here. So our right side of the heart isn't just one chamber, correct? I think you guys are good on that. It's separated into two, the atria and the ventricle, and it is separated by the tricuspid valve. If you want me to write that out, I can. The tricuspid valve separates the atria from the ventricle in the right side of the heart. But if blood gets through into the right side of the ventricle, then we have the pulmonary artery, right, that takes blood out of the right side of the heart and it delivers it to the lungs. But we actually separate the pulmonary artery from the right ventricle by another valve, which is our pulmonary valve. So this allows us to kind of shut the door on the heart from the vascular system during systole and diastole. So blood will go all the way through the lungs. This is, again, very not anatomically correct. And it would leave the pulmonary vein to go into the left side of the heart. The left side of the heart is separated, right, into the atria and the ventricle by the mitral valve. And if you need help remembering, mitral has an L in it for left side of the heart, where tricuspid has RI, which is the first two letters of right heart failure. So tricuspid goes on the right, and mitral valve, you drag out the L, mitral valve is on the left. For many years, even when I was teaching this class, I would just say mitral a little longer as my little mental verbal cue just to visualize the left side of the heart, mitral valve, and I would be like, I'm on the left. So use the tricks that you need to get yourself through. Some of this stuff isn't necessarily intuitive. Okay, so the left ventricle will pump out to the periphery, right, via the aorta. And the aorta can be physically separated from the ventricle by the aortic valve. The aorta gets smaller, 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 smaller. Smaller, 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 until it becomes a single capillary, right? The arteries get smaller and smaller and smaller. And then the deoxygenated blood is going to enter the veins, and the veins slowly get bigger and bigger and bigger. My slide is running out for them to get bigger and bigger and bigger, and then get dumped back into the heart. So for a single red blood cell, it can take this entire trip, but we don't move from the right side of the heart to the left without moving through the lungs first. Since we took the time to draw this picture, let's play with it a little bit, and let's just sprinkle in a little bit of a review from the beginning of this unit. We have been talking about atherosclerosis and the formation of atherosclerotic plaque. Where does atherosclerosis form? Where do we see plaque? Can we add it to this picture? Where would it go? Let's see, maybe let's make it green so it's like real nasty. Where would it go? It would be in our arteries, right? Atherosclerosis grows in our high pressure, high flow arterial system. So let's give this guy or gal some atherosclerosis. It's not actually green in anatomy. Don't be confused. I'm just trying to make it seem real nasty. All right. Here is our atherosclerotic plaque. And we talked about how atherosclerosis can decrease blood flow, right? Because you can see the lumen has gotten much more narrow. But another thing that can happen is it can ulcerate and you can get a clot. So what if we had a sudden ulceration and we formed a clot? Here is a blood clot. Well, that would suddenly obstruct blood flow to anything downstream. But this is going to happen, it's going to come into play in the next couple of lectures here. That clot that we just formed actually could break free, right? Like it's stuck right there, but if we had enough pressure coming behind it and flow, this guy could actually get knocked free, right? Where would that blood clot go? If this blood clot formed from an ulcerated atherosclerotic plaque got knocked loose and become an embolism, it could fly forward, right? Blood flows behind it. Where would it stop, or where would it go? It will continue to move until the diameter of the blood vessel is just the same size, if not a hair smaller, than the blood clot itself. It would stop on the arterial side. There is no way a blood clot formed in an artery would be able to get through a capillary because it's just too small. So a blood clot formed on the arterial side can become an embolism, but it will have to land in the arterial side of the tree. So where might that go? Well, if this artery was leading into the heart, it could land in a smaller coronary vessel. If this artery was heading to the brain, it can go until it hits a slightly smaller artery in the brain and then completely block blood flow to the brain and occlude flow to the brain, causing a stroke. So when we talk about atherosclerosis and the chance of it forming a sudden infarction or a blood clot, that is going to block blood flow on the arterial side. But we also spent a bit of time talking about thrombosis and the ability of forming blood clots in veins. So what if this guy here, what if the clot was here? So this would be a clot that might have been formed from immobility or vascular damage or an indwelling line of some kind. So this is a clot that's formed on the venous side, right? We're on the veins. And it can break loose. So if it breaks loose and becomes an embolism, where does it go? Or where does it stop? Maybe I should say. Well, the container that's holding that clot is just getting bigger and bigger and bigger. There's nothing stopping this clot because the veins go from small to big. And this clot will drop into the atria, plenty of space for it there. It'll drop right into the ventricle, and it will completely keep on moving until it hits a vessel in the lungs that is just slightly smaller than itself. And now we have a PE, a pulmonary embolism. So a pulmonary embolism is from venous clots because of how we follow the anatomy. Blood clots from atherosclerotic plaque cannot cross all the way across a capillary into a vein and then somehow get to the lungs. They will get stuck somewhere along the way before they get there. Okay, so we have been kind of ticking through all the ways in which we can describe heart failure. Whether it's within the heart or outside of the heart, the timing of it, if it's acute or chronic, whether it's which cardiac cycle it's affecting, whether it's affecting the systolic or the diastolic. And now the reason I went to that time, really separating the heart, ripping it apart in that diagram, is because the final separation comes from whether the failure is on the left side of the heart or the right side of the heart. And it would mean then it's a failure to either maintain cardiac output coming out of the left side of the heart or coming out of the right side of the heart. And these look very different clinically because of what you know about the anatomy of the cardiac system in parallel with the lungs. Now, the left side of the heart's going out to the periphery, the right side of the heart is pumping to the lungs. So let's first walk through what happens with left-sided heart failure. So I'm just going to draw, let's do one lung here. Here's a lung, and I'm going to put the heart next to it up here, and I'm going to draw it in that same way where it's a heart that's been ripped in half. Within the lung, just to keep it simple, I'm going to draw the lung as like one single bronchi with an alveoli. So in the lung, right, we have our blood vessels come through, and they go right by that alveoli. So let's draw a little blood vessel. It goes right by it. And then the whole thing is going to come out as the pulmonary vein heading to the left side of the heart, right? So this is the left side of the heart because it is receiving blood from the lungs. The left side of the heart is divided into the atria and the ventricle by the mitral valve. So it's interesting to think about left-sided heart failure because it's going to be very much tied in with the function of the lungs. So consider a patient who's in front of you and they're very short of breath with activity, like inappropriately so. Like the activity you've given them, they're breathing much more difficult than they should for what you've given them. You kind of say to yourself, okay, this patient seems like they have something wrong with their lungs. Then they likely do, depending on many other factors. Now, when you're considering what might be affecting the lungs, they could have lung disease, right? The lungs could be directly affected. There could be a pathology in the lungs that's causing the shortness of breath. But the lungs are so dependent on the cardiac function that the lungs could actually be causing the shortness of breath, but it may be indirectly because of some underlying cardiac disease. So how does the heart affect the lungs? Okay, well, here's the left side of the heart, and we said it pumps out to the main periphery via the aorta, right? So I'll just kind of do a little truncated aorta here with blood going out to the periphery. So this is our aorta, which is how we get the blood out of the left side of the heart. So correct me if I'm wrong here, but all congestive heart failure is reduced cardiac output, correct? Correct. Have I brainwashed you yet? Okay, so what does that mean? I keep saying it over and over again. What does that mean if there's reduced cardiac output? What's happening in our picture? Reduced cardiac output out of the left side of the heart would mean that we have decreased blood flow, right? Coming out into the periphery. Well, if you have decreased blood flow, let's say because the left ventricle can't pump as well, for example. So let's say you have some kind of systolic dysfunction. You're not squeezing hard enough. It's reducing blood flow, getting pumped out. If you have less blood flow going out, you still have the blood coming from the right side of the heart, right? The right side of the heart really has no idea there's a problem on the left at this point, and it's doing its job. It's pumping in the lungs, happy as can be, maintaining its own cardiac output. And all that blood is going through the lungs and getting dumped on the left side of the heart. But the left side of the heart can't pump as well, and it's having reduced blood flow leaving. which means pressure is going to build up in the system behind it. Because you can't get all the blood flow out and it keeps on coming from the other side, that's ultimately going to build up pressure in the pulmonary vasculature. Okay, what does that mean to us clinically? If we're increasing the amount of pressure in the pulmonary vasculature, there'll be increased pressure all the way along, right? Increased pressure, increased pressure. What kind of a blood vessel is this guy right here going right by that alveoli? Well, that's going to be a capillary, right? Because that's where we have gas exchange. If we're saying we have increased pressure, what's another way of saying that? Another term that we've used a lot this semester. This is going to increase the hydrostatic pressure within the pulmonary vasculature. Let's zoom in on that. What if I zoomed in on this little vessel that I'm pointing an arrow? Okay, so here it is. And the blood's going through, and there's capillary hydrostatic pressure is out, and capillary oncotic pressure is in. And we suddenly increase the outward pressure. What is going to happen? Hopefully you all know it, right? Fluid is going to leak out. Basic Starling's principles. Well, if fluid leaks out, where does it go? We're in the lung. And this little capillary is right up against the alveoli. So some of that fluid can actually go into the lung and fill up those little sac-like spots in the lungs, the alveoli. If you get fluid building up in the alveoli, that is called pulmonary edema. Pulmonary edema is the accumulation of fluid in the alveoli. But this is also, the alveoli are within the lung, and the lung is within the thoracic cavity, but right, the whole lung has that pleural space around it. So if the fluid is leaking out, some of it might go, let me just change my color so you can see. Obviously, some of that fluid can go up into the alveoli, but it can leak out as well. So the fluid can leak out and actually accumulate in the pleura, or that space, that area around the lung. And then gravity is going to pull it down to the very bottom, because fluid is going to be very dependent on gravity. Just like the reason that fluid stays in the bottom of your cup that you're holding, gravity pulls it down. So when fluid leaks out of the lungs and it leaks out into the pleural space, it generally gathers at the bottom of the lungs when we're upright. So this would be called pleural effusion. And I made it green only for you to be able to see it in the picture. But these are both would be made of the same type of fluid. Pulmonary edema and the pleural effusion, in this case, these would both be transudative edemas. Transudative fluid. It would be low protein because the only thing we changed was the hydrostatic pressure in the vessels. So this patient has a cardiac abnormality, right? They have something that's causing them to have reduced cardiac output on the left side of their heart. But because of that, because you can't pump the blood forward, pressure is going to build up in the system behind you. The system behind the left side of the heart is the lungs. So pressure will build up in the vasculature of the lungs. Once we see high hydrostatic pressure in the capillaries, well, that's where fluid can leak out. Capillaries are just those single endothelial cell vessels. High hydrostatic pressure, not enough oncotic pressure to offset it, and fluid will leak out. Now we have fluid on the lung. Now we have our first symptom of heart failure, left-sided heart failure. And patients can start to experience shortness of breath. Dyspnea is a term that refers to the subjective sense that you're having a difficulty breathing. In fact, this picture is where the term congestive comes from in congestive heart failure. We call this congestive heart failure because the congestion is the fluid that backs up because of the heart failure. So CHF is congestive heart failure, and the congestive is because of all of the problems with fluid backing up and leaking out into parts of the body. So I said this is our first kind of symptom, clinical presentation of this heart failure. I said they might have some shortness of breath, difficulty breathing. Other things that you might experience is when they breathe in, if you listen to their lungs, you can actually hear crackles. Like it almost kind of sounds like Rice Krispies, like snap, crackle, pop, when they breathe in. And that is because of the air sacs that get snapped open, that got closed with the fluid. And you can, this is something, we'll get into a lot more detail about this in cardiopulm, but this is something we can actually document with therapy as a response to activity, how well they tolerate it based on some of the lung sounds that we hear and can document during therapy. So all of cardiac output is a failure to maintain cardiac output. But now we're going to start talking about the clinical implications. If you can't pump the blood forward, the blood's going to keep on coming, right? And it's going to build up in whatever system is right behind it. So when you have left-sided heart failure, the fluid builds up in the lungs. So now let's talk about when the right side of the heart fails. So let's just draw a diagram in here. Okay, so here we have the right side of the heart ripped off from its left side. And the, let's make it orange. The right side of the heart is going to receive blood, right? I'm going to draw it this way so it kind of keep the orientation. It's going to receive all of the lower extremity blood is going to come up from that inferior vena cava. And then kind of all the upper extremity blood will kind of feed into the subclavian vein. Let's see, these guys kind of branch off to the jugular, and we kind of go in. This is why I probably shouldn't teach you guys anatomy. So this guy kind of feeds together for here to be this guy here. Let's put a box around inferior vena cava for this guy. And here we have the superior vena cava. So all of the upper extremity blood coming from the superior vena cava. We can see the jugular veins are here. Hope that picture makes sense. The red and the orange are a little tricky. The red, the heart's behind it, the blood's coming through. All right, let's send all the right side of the heart blood will head out and get dumped into the lung. This is lung. Okay. So here's kind of the framework for the right side of the heart. It's receiving all of the venous blood either from the lower extremity through the inferior vena cava or the upper extremity from the superior vena cava, collecting all that deoxygenated blood and pumping it into the lung. Now, some things to know about the right side of the heart, if you're not already kind of having this in your brain, is that it is much, much weaker than the left side of the heart. The job of the right side of the heart is much easier, right? It has to pump into a much lower resistance. Our pulmonary system, right, has a much lower pressure than the peripheral pressure. So our pulmonary artery pressure is typically like 25/10, where the aorta is like 120/80. So the right side of the heart doesn't have as much to pump into, so it has much thinner ventricle walls. So it is much more susceptible to any disease that raises pulmonary vascular pressures. So anything that raises PA pressures is very, very difficult for the right side of the heart to overcome. So a good example of this would be pulmonary hypertension. When you raise the pressure in the pulmonary system, it increases the demand on the right side of the heart and it cannot maintain cardiac output. If the right side of the heart can't maintain the cardiac output to the lungs, that is heart failure. So anything that raises PA pressures can lead to right-sided heart failure. Of all the causes that might cause the right side of the heart to be unable to keep up with demand, the most common cause is left-sided heart failure. So we commonly see these together because what just happened on our previous drawing? When the left side of the heart couldn't maintain cardiac output, it raised pressures in the pulmonary system. Now we have very high pressures in the pulmonary vasculature, and the weak right heart is pumping into those high pressures, and eventually the right side of the heart fails. There are many other causes of right-sided heart failure, and you can have it completely independent. This is the mechanism whereby right-sided heart failure is the mechanism whereby many people die of a pulmonary embolism, because if it's a very large pulmonary embolism, the complete blockage and the sudden elevation in pulmonary pressures causes the right heart to fail, and that is actually the cause of death. So it is not dependent, right? You can have right-sided heart failure independent of left-sided heart failure. It's just that it's the most common cause. So if the right side of the heart is failing, which means that there's a reduced cardiac output, it's not pushing the blood forward, what has to happen? Pressures have to increase in the system behind it. So we see increased pressures in the peripheral venous circulation. Since the right side of the heart receives the blood from the venous system, if it can't pump that blood forward, eventually fluid will build up in the system behind it. So that's where I kind of added a little extra anatomy here. You can see, the jugular veins come right off really the top of the heart. Right? The superior vena cava feeds from the jugular vein. So if pressure is building up, whoa, go away. You can see the jugular veins actually become large and distended. They're in a visible part of our neck. So really enlarged jugular veins is a big clinical sign of right-sided heart failure. It's kind of almost like a little barometer coming straight off the top of the heart. And as pressures rise, they begin to bulge. But you can see all the blood backing up through the inferior vena cava, going from the lower extremities and all the GI system that can increase those pressures. All right, let's bring it all together and talk about the signs and symptoms. We've already kind of begin to hint at these. These are listed out in the next part of your notes on page 51. So the first sign and symptom is going to be shortness of breath and dyspnea. Dyspnea, again, is a difficulty breathing. Now, for signs and symptoms in this class, I really encourage you, and we're going to do it together, to link them back to the exact pathology. This will make it much, much easier to learn than memorizing the steps of pathology and memorizing symptoms, just disease after disease after disease. But rather, if you can think about how a system normally works, now it's broken, how has that changed? How do the changes from the disease look like on the outside? So hopefully this already is kind of coming into your mind. Shortness of breath, dyspnea. What do we talk about that might lead to shortness of breath and dyspnea? Well, when the left side of the heart is failing and fluid backs up in the lungs, the fluid in the alveoli is going to disrupt our ability to participate in gas exchange. Right? It's going to be really hard for oxygen to get into the blood if there's a bunch of fluid in between that barrier. If there's fluid outside of the lungs, that actually can restrict your ability to fill your lungs, right? If there's a bunch of fluid on the outside and you take a deep breath, it's not going to let your lungs stretch and fill. So the fluid on the lung can cause shortness of breath and dyspnea. Now, there's a little asterisk on here because I'm going to come back to this one. There's a second reason that we have shortness of breath and dyspnea, but let's just stick with what we've talked about so far. So far, I've basically introduced the concept of all this congestion and how fluid can build up on the system behind it. So let's stick with that right now when we look at signs and symptoms. All right, the next symptom is orthopnea. Orthopnea means shortness of breath when you lay down. Okay, orthopnea means shortness of breath when you lay down. And paroxysmal nocturnal dyspnea is shortness of breath that wakes you up 1 or 2 hours after you're sleeping. Okay, so let's first talk about just the orthopnea piece because it kind of plays into the paroxysmal nocturnal dyspnea. Here you're a person with heart failure and you have been unable to maintain cardiac output and fluid is accumulating in the peripheral venous circulation. So you've got extra fluid in your legs. You're standing upright and you probably have fluid building up in your lungs, but it's kind of all on the bottom of your lungs, which means there's a lot of your lung that is very unaffected by the fluid and you're getting good oxygen. Then you lay down. Okay, when you lay down, all the effects of gravity on that fluid go away. And a lot of the fluid that's accumulated in your venous circulation goes dumping back onto the heart. And it's even more difficult for the right heart to keep up because of this overwhelming amount of fluid, and it makes the heart failure worse. The distribution of fluid in the lung is no longer just at the bottom, but now we've got kind of fluid throughout the lung, which also contributes to the orthopnea. So laying flat can make the shortness of breath worse. So the paroxysmal nocturnal dyspnea, or the shortness of breath that kind of wakes you up 1 or 2 hours after you go to sleep, is really the same mechanism as orthopnea. When you lay down, the fluid redistributes and it kind of dumps on the right side of the heart and kind of overwhelms the lung. But when you sleep, on top of that, we have reduced adrenergic activation. That's kind of a fancy way of saying we have kind of a lower amount of sympathetic activation. So our heart is beating a little slower and with a little less force when we sleep. That's what it means by reduced adrenergic activation. So with less sympathetic activity at night, which means your heart isn't beating as fast or as hard, and then you're also compounding it with this fluid, they get into real trouble, cardiac trouble, because of the inability to maintain cardiac output in that situation. Their heart failure gets worse when they lay down and when they go to sleep. Jugular vein distension, we already talked about. That's the bulging of the jugular vein. It's actually visible from the outside of the neck. This is evidence of increased pressure in the right side of the heart because the jugular veins coming right off of that superior vena cava, and it's basically giving you a visual representation of the pressure in the right side of the heart. Ascites is fluid that accumulates. Oh, I forgot I had a picture. Excuse me. Sorry, this is I was thinking it was going to pop up. Here's the jugular vein distension. So you can see here the bulging jugular vein, excuse me. So we got our superior vena cava coming off the right side of the heart. And as that pressure builds, the jugular veins actually bulge out with pressure. And you can see that in both pictures. So edema, we have been talking about a lot, right? That's an increased fluid in the interstitial space. And we see edema in multiple places in heart failure, but a really big evidence is in lower extremity edema, or sometimes referred to as peripheral edema. The reason it's so much worse in the legs and other parts of the body is because of the effect of gravity. So when you stand up, you actually have higher pressure in your lower extremity venous system than you do in your upper extremity, just because of the effect of gravity. So the hydrostatic pressure will be more exaggerated in the lower extremity, and fluid leaks out, causing edema. Now, I included this area here to talk about the idea of pitting edema versus non-pitting edema. And I wanted to introduce this concept. I had mentioned when we talked about Starling's forces that as PTs, we do a lot to assess edema, and we can document on it, we measure it, we do interventions to alter it. It's very important that we have a good understanding of edema, which is why I really hopefully kind of hit you over the head with the Starling's forces. So as you guys know, at a blood vessel, the forces acting, right? You have a capillary hydrostatic pressure, which is an outward force. You have a capillary oncotic pressure, which is an inward force. And maybe a hydrostatic pressure of the interstitial fluid kind of pushing out, and some oncotic pressure of the interstitial fluid pulling away. When you have a disruption in Starling's forces, fluid can leak out. Now, that fluid would be transudative in nature, right? Because the proteins are still trapped and just the fluid has moved, because proteins can't cross the capillary membrane. So we can assess this fluid by seeing whether or not it pits to pressure. What that means is pitting edema is the ability to displace the fluid with pressure. So with pitting edema, as you can see here, you basically just take your finger and you press into the skin that has the edema. Now, what are we doing when we pit, or when we put that pressure on? We are drastically increasing the interstitial hydrostatic pressure. We're decreasing the size of the container of the interstitium. We're elevating the interstitial hydrostatic pressure to drive the fluid back into the vessel. I'm going to draw this out where it's not so busy. All right, so here is our vessel. Let's put some skin over the top. Capillary hydrostatic, oncotic, maybe some oncotic interstitial sucking. And here we have that hydrostatic interstitial fluid. Normally, in normal physiology, this is almost zero, right? Because the container is so vast, the fluid can just move. In pitting edema, you take your finger, here you go, this is your thumb coming to push down, and you push into the skin, right? So you compress this down. By decreasing the volume right underneath the pit, let's say just this area right here, you raise the interstitial hydrostatic fluid pressure, and it drives fluid back into the vessel, just right underneath your pit. So then you take your thumb away, and a little spot is left in the skin. That is pitting edema. This is evidence of a transudative edema, because we are able to overwhelm Starling's forces to push that fluid back in. And then we can rate the edema based on how deep of a pit we get and how fast it takes for it to refill back up. So this chart is in your notes where you can grade it. If it's 2 millimeters or less and very quickly it pops back out, that's just a 1+. If it's 6 to 8 millimeters deep and takes a long time to replenish, that could be a 4+ pitting edema. So pitting edema works because we exert an external force that alters Starling's forces just right underneath our thumb. We drive the fluid back in. As soon as you take your thumb away, right, this goes away too. And all the pressures go back to normal. And if the situation was that fluid was leaking out, as soon as your thumb gets taken away, it will slowly leak back out, right? And the edema will kind of refill in that pit. In your notes, you can see there's also what's called non-pitting edema. Non-pitting edema is when you press your thumb into visible swollen tissue and it doesn't leave a pit. This is a very common finding in an exudative edema. And the reason for that is, let me just erase this mess so you can see it a little bit better. Here's your vessel. Here's some capillary interstitial pressure. If it's an exudative edema and you have tons of proteins that have leaked out or been unable to be cleared, and each one of these proteins is exerting and holding the fluid towards it, the oncotic pressure of the interstitial fluid can be so great, such a large amount of force holding fluid into the interstitium, that when your thumb, I gotta erase my X'd out thumb here so you can see the thumb is back and better than ever. Thumb pushes down and it raises the interstitial hydrostatic pressure, but in non-pitting edema, the interstitial hydrostatic pressure cannot equal or exceed the oncotic pressure because there's so many proteins. So when it's exudative, we might not even be able to exert, that force doesn't overwhelm the oncotic pressure of the interstitial fluid, and there is no pit. So in heart failure, you would expect to see pitting edema because it's driven by a high hydrostatic pressure, and we can take our finger and we can overwhelm that elevation in hydrostatic pressure and for a very temporary period of time, drive it back into the vessel, and you can see evidence of a pit. The next symptom is ascites. And ascites is when you accumulate fluid in the abdomen. And this is a result of fluid leaking out from the GI system vasculature, from the high pressures within the circulation of the gut. Fluid leaks out. And you can visibly see that as accumulating in the abdomen. All right. So at this point, we have talked about a whole host of clinical symptoms that are all a result of fluid backing up in the system behind it, whether it is in left-sided heart failure and it backs up in the lungs, or right-sided heart failure and it backs up in the periphery. But some of you might have already been kind of wondering, isn't it a problem if we're not pumping blood forward? Hopefully that thought maybe crossed your mind at some point. It's a huge problem. We need to pump our blood forward. Cardiac output is important because it delivers blood to our whole body. And if heart failure is a reduction in cardiac output, wouldn't there be signs and symptoms associated with the reduced cardiac output? And the answer is absolutely yes. So the first one that we'll add to the next symptom that we'll add to the list is actually a result of the failure of maintaining cardiac output. If you can't pump blood forward, you are not going to be delivering enough blood and oxygen to the tissues that need it. And patients are going to experience fatigue and weakness. A big place that matters a lot to us is skeletal muscles will not be being delivered enough oxygen. That is going to give a sensation of being so fatigued, difficulty moving, difficulty doing ADLs because they're not delivering enough oxygen to the muscle. This failure to deliver enough oxygen to the body is what also contributes to the shortness of breath and the dyspnea. So when I said we have a little asterisk there and that we're going to come back to it, patients can experience shortness of breath both because of the direct effects of fluid on the lung in left-sided heart failure, but also as a result of an inability to deliver enough oxygen to the periphery. You get that feedback loop to the brain that you're needing more oxygen, and it creates a sensation of shortness of breath and dyspnea. Similarly, drowsiness and change of mental status is related to the reduced cardiac output. If you are not delivering enough oxygen to the brain, there will be changes in mental status and can cause a lot of drowsiness. So all of these different ways of classifying heart failure are describing how you might end up in a situation with reduced cardiac output. We are, in the next part of this lecture, we're going to get into how our body handles this and how it tries to compensate and keep us going when we're not maintaining cardiac output. So this is going to, again, get us into a review of some of our basic cardiac physiology. It's very important to remember and think through what makes up cardiac output. Cardiac output is the amount of blood that we are pumping out per minute. So it's in liters per minute. And of a normal cardiac output, we would expect that we can pump out about 5 liters per minute. So in heart failure, you're not maintaining that kind of normal status. The physiological equation we use to describe cardiac output is heart rate times stroke volume, because the rate tells you kind of how much per minute, and the stroke volume tells you the volume that we're getting per beat. So if you break up these two components of cardiac output, it can give us information on how our body can adjust and try to compensate when we start going into heart failure. So if we're not maintaining cardiac output, and cardiac output is made up of heart rate and stroke volume, could we use heart rate to help a failing heart? What controls heart rate? Well, we have an intrinsic heart rate, right? It's driven by the SA node in our heart, but our heart rate is strongly influenced by the autonomic nervous system. That's ANS, autonomic nervous system. So if you wanted to increase heart rate, what could you do? Well, you could increase sympathetic output, right? So if you increased sympathetic output, you would actually have more beats per minute. You'll increase heart rate. It's pretty cool. It's actually, the SA node is directly innervated by the sympathetic nervous system. So it's a very quick response. As you probably have noticed, anytime you suddenly realize there's a quiz in a class that you weren't expecting, your heart rate goes up almost before you even think about the fact that, oh my gosh, there's a quiz I haven't studied. Your heart rate's already going a mile a minute. Direct neural innervation that happens so quickly. The benefit here, we'll get kind of a little side note, if you activate the sympathetic nervous system, it both increases heart rate and it increases contractility. So that's a big bonus that we'll get to in a second. So if your heart is failing and you're not maintaining cardiac output, the things you have to play with to try to make it better are heart rate and stroke volume. If we want to change heart rate, we're going to need to change the autonomic nervous system or activate our sympathetic output. The other thing we have to play with is the stroke volume. And so to understand how we can try to help a failing heart that's not maintaining cardiac output by manipulating stroke volume, we have to remember what contributes to stroke volume. So once again, stroke volume is the volume of blood pumped out per beat. A typical stroke volume is kind of like 70 milliliters. Kind of give you an idea of how much blood is being pumped out per beat. It is very dependent on preload, afterload, and contractility. So let's talk about each of these separate. And this is, again, just kind of weaving in that cardiac physiology review. So preload can kind of loosely be just defined as ventricular filling. So preload is the volume of blood in the ventricle at the end of diastole. How much blood gets in there right before the heart contracts. So we often describe preload as end diastolic pressure. LV is left ventricular end diastolic pressure. And I realize every year it bugs a few of you. It might not have crossed your brain, but some of you are probably a little bothered by the fact that I defined preload as a volume, but then we measure it as a pressure. And that is annoying, and it's kind of just how it is. Preload is technically a volume, but way we measure it is as a pressure, because as the volume goes up, so does the pressure. So I apologize if that bugs you. It kind of always bugged me, but it's just the way we do it in physiology. So it should make sense that as we increase the volume in the heart at the end of diastole, we would be able to pump more blood out. So on this graph, we see preload on the x-axis and stroke volume on the y-axis. And more in equals more out. It's pretty nice and simple that way. And hopefully that makes sense. More in, more out. And if it helps you, for me with the heart, it really helps to always go to that water balloon analogy. If you take a water balloon and you fill it with 100 milliliters and you open the top and you squeeze it, a certain volume will come out. If you fill that water balloon with 500 milliliters and you squeeze at the exact same force, more water will come out. More in equals more out. So that's an easy way of thinking about preload. But what's interesting is if you graphed that, that should be a linear relationship, but it should actually look a little bit more like this red dotted line. As you increase end diastolic volume, we should directly see an effect on stroke volume. But what's interesting is there seems to be some kind of extra benefit here, that there's more going on than simply more in equals more out. We're getting more volume out than can simply be accounted for by the volume that's coming in. And this phenomenon is known as the Frank-Starling mechanism. The Frank-Starling mechanism shows us that as we increase the volume in the ventricle at the end of diastole, we actually increase the contractility. Remember again, the contractility is the force of the heart. So I said, when we're talking about that water balloon, more volume in, more volume out, and if we squeeze the water balloon with the exact same amount of force, you would expect more water to come out. But what Frank-Starling mechanism shows us is that as we increase the volume in the heart, we actually squeeze it out harder. The stretch on the wall of the ventricle stimulates a stronger contraction. So it kind of augments the effect. For those of you that care or kind of know more about like the cellular physiology of the heart, if this helps you remember this, there are actually stretch activated calcium channels that when you stretch a myocyte, it opens calcium channels and more calcium comes into the heart. More calcium in a myocyte gives you a greater contraction. So it's a direct mechanical effect of the stretching of the myocyte, which is very, very cool. So preload influences stroke volume because the more volume in equals the more volume out. But on top of that, it activates the Frank-Starling mechanism whereby as we stretch the walls of the ventricle, we stimulate a greater contractility. So we get a double whammy, increased volume, and it stimulates the contractility. Afterload kind of has the opposite effect. So right afterload is the resistance that the heart has to overcome to pump blood out. We largely think of afterload as kind of thinking of it as aortic pressure. I really love this cartoon, how it kind of shows this almost like stopcock on the blood coming out of the heart. It's like it really gives you the visual of if there's a lot of pressure, you just can't push that blood out. So the normal line is the line from the previous figure, that as the end diastolic volume goes up, stroke volume goes up. Obviously, it's a little bit more than you'd expect because of the benefit of Frank-Starling. But as you increase the afterload, or you increase the ventricle, the resistance the ventricle must overcome to push blood out, you actually drop that curve down and reduce stroke volume. The heart will need to generate such a greater amount of force to get the same blood out that the resistance on the left ventricle will reduce the total amount of blood that can leave the heart. So some examples of increased afterload. Hypertension, I think, is the easiest one to get your mind around, right? If you've got high peripheral pressure, the heart is pumping into a high system. But another example is valvular stenosis. So here we see the aortic valve that is very stenotic and hard, and it's not those nice flappy little, movable bands of tissue, but really stiff flaps, I can't think of another word of saying it, that don't open very well. And the heart has to create an enormous amount of pressure to squeak blood through this little hole because these flaps are not going to open during the contraction. And that raises the afterload, which will reduce the total stroke volume. So stroke volume is influenced by both preload and afterload. Preload is how much volume gets in the heart right at the end of the diastole. More preload, more blood to pump out. Afterload is the load after the heart. It's the pressure the heart is pumping into. The greater the afterload, the worse the stroke volume. And then the last piece that we have to play with is the contractility. And contractility, again, is the force of the contraction. So this green line now is our normal curve that we've been describing over and over again, that as the volume in the heart goes up, so does stroke volume. But what we can add on to this is if we add contractility, right, we can augment the effect of the volume. So we've already talked about that in terms of how Frank Starling stretches the myocytes, stimulates an increased contractility. But the other way of doing that would be with sympathetic activation. If we activate the sympathetic nervous system, the ventricle is actually innervated by sympathetic nerves and can make it squeeze harder. If you can squeeze harder, you can get more blood out per beat. You can raise stroke volume. So I'm going to end it here for right now, and we can pick up in the next video. We're going to play with each of these to show how someone who's in chronic heart failure can actually compensate for that heart failure for a long, long time. Thank you for your attention.